Today on the Reality Pill, we have a very impressive surgeon and artist, Dr. Marc Mani. Dr. Marc Mani is a plastic surgeon out here in Beverly Hills, specializing primarily in deep plane facelifting, rejuvenation of the face with fat and the mist procedure, which he'll tell you about, and doing amazing breast surgery and rhinoplasty as well. We share a lot of ideas, like to bounce them back and forth to help each other understand the face better. He's got a profound understanding of facial aging, why and how it occurs, and he loves teaching other doctors and patients about it. And I love listening to him because he's got a much more eloquent way of explaining things than I do. I'm much more simplistic. So I'm very excited to have Dr. Marc Mani here. Thank you so much for joining us.
Thank you. Yeah, well, I'll just say that I've looked up to you too. I mean, I remember, how long ago did you start your practice?
About 5.5 years now.
Yeah, so I mean, I remember seeing you before I met you, just seeing your website, and I saw your work, and I was like, this guy's really talented. And so, and I also really appreciate and respect the passion that you bring to the field, because that's something that it's clear that you enjoy it, you're naturally good at it. And so, and I know we've exchanged videos and pictures of interoperatively, and I've learned facial anatomy from you, and hopefully vice versa. But no, I really respect your work, and I love your work. And so,
Yeah.
it's an honor. Thanks for having me on.
No, thank you. So I think we've got a lot of things that I want to talk to you about, but the main thing to start with, I'd say, is kind of waking up the world to different kinds of facelifts. And I'll just give kind of a broad explanation for people who don't understand facelifts. And a facelift and a neck lift are essentially the same thing, very, very similar. And what we're trying to do is just reverse gravity. So everything kind of drooped down over time and we want to take it back up. And the classic way that everybody was taught initially started with just skin elevation and kind of pulling back the skin, which what they called a rhytidectomy, so getting rid of wrinkles in the face. But we've progressed since then, not just trying to remove wrinkles, but actually lift soft tissues that have been drooping over time. So the majority of the world still probably does some form of mass plication, meaning they lift the skin one way and they tighten the muscles underneath another way. And there's different muscle layers, but they kind of just grab all of them and tighten them underneath. And then there are advanced forms of that, like lateral mastectomy, like Dan Baker, and where they grab closer to the deep plane entry point. And then you get into the deep plane world. Deep plane is what Dr. Mani and I both do. And it is similar in terms of access points coming in through the face. And you go just release everything in the face to lift up the skin, fat, muscle, kind of all together. So we've found that to be very effective and kind of stick to that. And the rest of the world seems to slowly be changing and kind of listening, because now everybody sees that the superior results are either coming from incredible surgeons or just in general surgeons who are using these kind of techniques. But what have you seen in terms of that kind of regime change and what's
That's
been
a
going on?
great question. I agree with you. I mean, I think a lot of people would make the point that a great facelift result is, partly, if not, at least half, 40, 50% contingent upon the artistry and the gestalt, the aesthetic gestalt of the surgeon. I mean, look, if you look at Dan Baker's work, I mean, it's a mastectomy and in theory, kind of an old fashioned facelift, but he's very artistic and he knows the face. He's very efficient. And that's why he developed that great reputation. He's a great teacher. I think the reason that maybe people are kind of coming onto the wagon of deep plane and composite flap, whatever, you call it, lifts is, honestly, partly social media. People see Instagram, people with a good eye can tell that the only way to really sort of naturally revolumize the face, and also, and this is something I noticed about yours, Ben, is that in order to really get a nice full and youthful jawline, but it's still smooth without the, typical complications in the neck of irregularities and skin problems, you have to lift the SMAS and platysma as one unit. It's one cohesive sheet. I tell patients it's like a hammock that goes from, cheekbone to cheekbone. And I think that we both do that in a pretty similar way. As far as the regime change, I think that's, part of it is just there is a visible difference. And it's, I say to people, a facelift done improperly or quickly is a pretty simple operation. It's a skin operation with the SMAS plication. A facelift done well is probably one of the hardest operations in all of surgery, not just plastic surgery, but I mean, including brain surgery, because we're right on top of the nerves. The tissue planes are very delicate. You have to have a very steady hand and touch and knowledge of the anatomy. And, it takes a long time to really get it down. And it's artistic. So that's what I've always loved about it. From the first one I did as a resident when I was 28 years old, I did a lot of facelift as a resident because I had a program where we happened to do, and I know you did too, in a private sort of a resident clinic. And I knew from the first one I did, the patient, I still remember her name was Mary. She took off her dressing and she was so happy she started crying. And so it was good for me to make someone cry out of happiness for a change. And but it was just a great feeling, and it's a great specialty of surgery. But you're right, the regime is kind of changing.
Yeah, and so I like to tell patients who are looking for the best result, you look for the best result. Doesn't matter what the name of the technique is. So it doesn't have to be deep plane mass plication, and certainly there's geographic considerations of where people live and want to do surgery. The result is the result. If a surgeon gets good natural results consistently, and a lot of them, doesn't matter what technique they're using. As far as education for doctors go, I try to tell them that when they're learning, I can give you substantial arguments for using deep plane because of the release of tension that you get and the ability to lift, but I can't give you very many good arguments for mass plication. And again, doesn't mean it's not a good surgery, but you have to be an exceptional surgeon to get a mass plication to really get a big result out of it in the face, because of the technique kind of lends it to that. You have to be very creative and have a lot of other little tiny techniques that you do at the same time. And one of them is fat grafting. So have you noticed that with deep plane lifting of the face or the mid face, that you don't really need to do as much grafting of fat, if any?
Yeah, absolutely. I think that, and it's a pretty simple explanation. It's the fact that, when you're lifting, when you go over zygomaticus major and you go into this portion of the mid face under the malar fat pad, if you know how to release all those ligaments, and it's not something that just anyone is trained to do, it takes a while, you're going to revolumize the cheek as well. And so you don't, I think, routinely have to, like I did one before the COVID crisis, right before it, where I had to do some fat grafting because the patient had lost so much volume here. But that's probably 1 out of 10 for me. And I know we share the same philosophy about fillers in particular, but when you add some, spackle or whatever you want to call it, the hyaluronic acid fillers so much to a cheek to revolumize them, you're destroying the purpose of the human face, which is to emote. And you're taking away the connection between the facial muscles, which are really the only muscles that are intended to move the skin in any part of the body. And you're destroying that function of the muscles. And you're adding just kind of this brick of filler there that also, as you pointed out, moves and changes. But that's why I like fat grafting. And I think I was interested in your opinion on this. I think that, fat has a lower specific gravity than filler too. And so it is going to be more, it's going to facilitate lifting more. It's going to kind of be fluffy. And also, as we learned, it improves the skin because of the stem cell action in the interstitial tissue that we both use, I know, for nanofat.
Yeah, I agree. Fat has different characteristics to it. It's much harder to control than filler if something goes wrong. So I'm much more cautious. I'm a little more, I'd say, courageous when I inject filler. When I inject fat, I try to be a little more cautious, just because if the person has any kind of reaction to it or congeals a little bit or anything, it's harder to fix.
Or if they gain weight, then it balloons up, and that's
right.
Not good.
Exactly. So I like that about deep plane lifts, that we can really decide whether or not we need to do it. It's not a lift that's dependent on it. Whereas I see typically with subperiosteal lifts, meaning kind of the endoscopic lifts or mass plications, in order to have a long lasting improvement in the face, most surgeons would have to add fat to it to get the volume bolstering effect there.
Yeah, absolutely. That's definitely a weakness of that technique. The other thing I always tell people as an argument in favor of the deep plane techniques is that most of facial aging is gravity pulling things down. Because you look at most faces, the argument that it's volume loss is sort of an argument that is foisted on us by filler companies and maybe non-surgeons or surgeons that don't do a lot of facelift, because it's a hell of a lot easier to lift a face with filler or just fat. But the problem is, if you look at an older face in general, the volume goes from here to here. It's still there. It just needs to be lifted up. Yeah. And I agree. I think it's a much more revolumizing technique. And that's one of the main reasons I've loved it for so long.
And that actually brings up an important point that I wanted to talk to you about, is what I think people don't understand well what makes the face age, and they can blame collagen, fat loss, telomeres. Like there's a million things I've heard blamed upon, and I want to hear how you explain it to patients, because I try to simplify it. I try to say, we learn a big word like collagen, all of a sudden everything's collagen. We learn a big word like DNA, telomeres, everything's telomeres.
Right.
So
Right.
I just simplify it to say, from what my small brain can comprehend out of all these things that's happening in your face, there's going to be some volume loss, and the volume loss, not just fat, but the different parts of your soft tissues. There's going to be drooping, and there's going to be skin quality changes. And I just kind of leave it at that. How do you explain to patients what's happening to tell them what they need?
Well, I think, as you probably agree, every patient is different. And I've definitely believe this more and more. There's no single magic bullet, even with the deep plane facelift. You have to look, and you have to be able to predict what kind of a result you're going to be able to get in that individual patient. And so some people definitely have more volume loss. So there's no generic kind of spiel that I give, but the one thing I do say, and you make it simple, I probably make it more complicated. I tend to go into more technical details just because I get kind of OCD about it. But I do say that gravity, it's mostly gravity, I think, and that depends on the patient I'm talking to, but I'll tell them, look, in your case, it's mostly gravitational change. And I think, we both know, when you do the deep plane dissection, it's a complicated dissection because the ligaments are so nuanced, and you have to know exactly where they are to the millimeter. But it's an easy dissection in the sense that you can use that like Trepsat dissector if you want to, or just your scissors bluntly, and it spreads apart easily, which tells you that is the layer that gravity acts on. And so I kind of go into that briefly, and I think that's something that most people will understand, that if you can just tell that deep layer slides so easily. And that's a part of the Brian Mendelsohn in Melbourne talks about this a lot. He's a genius anatomist and educator and facelift surgeon, and he talks about the evolved function of the face, which is that's one of the pitfalls of evolution, is that our face evolved to have sliding tissue planes for the purposes of mastication and expression and all those things. And so that's part of why we age. But yeah, you're right. I mean, it's just, to keep it simple, it depends on the patient, but there is volume loss, and there's also gravity. Both things are
And I think there's a lot to be said about the facial movements and how important it is to maintain them. Diffuse fat filling can deposit on the zygomaticus muscles very often, from what I've seen, and other muscles in the face. So I try to tell people that, when I'm doing fat grafting, or other doctors, where to place it, which is important. The other thing is that, with the benefit I've seen from deep plane lifts, is I leave all the mimetic muscles in place, and I'm just gliding that SMAS and platysma back over it and putting it right back down. So the kind of adherence and position of the mimetic muscle stays the same. And it's very hard to quantify that afterwards. But when I'm looking at patients who have either been pulled in the wrong direction or pulled too tight with threads or stitches, I tend to see that their facial movements have changed. And that contributes to part of losing their emotional expressiveness or looking a little bit fake.
That does, and I think also, one of the things they talk about, the lateral sweep deformity. Well, first, I'm sorry, back to the point about the mimetic muscles. You're totally right. I do think that that one thing I notice is that the SMAS platysma layer and this fibrous part of the SMAS layer does tie into the orbicularis and the whole complex of muscles. So you're right. You're not changing the position of them. You're over them in general, but it resets them in a way that makes the face look rested and refreshed and not pulled. And you can. I personally pull the deep layer pretty aggressively in a lot of cases, because you can pull it and you're not removing a lot of skin, you're not putting tension on the skin, and it may feel tight. I always tell patients it usually feels tight for a few days to 2 weeks, but it's not going to look tight. It generally doesn't look tight, except sometimes in the cases of secondary lifts, it's going to look a little tight for a couple of weeks. But that's the beauty of the deep layer techniques too, is that you're really not going to compromise the long-term result. It's still going to look natural. It kind of resets the smile, and the corners of the mouth, which always droop with aging, it kind of goes back to a neutral position because of the integration with the orbicularis.
And I feel that more so with deep plane than other techniques, and extended deep planes, which is what we do. There's more of a feel to it, of an actual feel of where the tissues are being tethered, where we're releasing them, and what vector to pull them in. Because for years, if you're reading all these articles that are focusing on lateral sweep deformities or lateral pull, vertical pull, posterolateral 45 degree, they're trying to find the appropriate vector. And the more deep plane you do, meaning the more you release in that plane, the less you have to think about vector. I've kind of gotten to the point where everything's by feel, and I feel where the vector of most release is, and that's where I reposition everything. And it happens to be like this. I mean, like, you know, you feel the face and it's by feel, and it happens to be in the direction of the mimetic muscles that are up on the cheek and perpendicular to the nasolabial fold, which makes sense because that's where they're all kind of attaching. So it's a perpendicular to here. That's where things tend to pull, but I'm not thinking of a number of 40 degrees to 60 degrees.
Well, you know, it's not color by numbers, and neither is good art. You know, I mean, it's, and I totally agree with you. When you do the deep plane technique, I mean, it just kind of comes naturally, and sometimes you just can't put it into words. You just know it by feel. This is where this should go, but it's along the axis of zygomaticus major typically. And I mean, every patient's a little bit different, but I think all the arguments, you know, with bilamellar techniques, which is what I initially learned from Tim Martin, who's just genius and a great educator since I was a resident, really followed him until I got to the point where I was doing the composite flap. And you're right. I mean, I don't remove a huge amount of skin in a lot of cases. I tend to get patients that are on the younger side for facelifts. And, you know, in LA, if you haven't had a facelift by the time you're 55, then you must not have been here for all that long.
You're behind.
And so, you know, and patients that have taken really good care of themselves. And I think one of the things that weight fluctuation and smoking, those are things we don't see that much in LA. So that's another thing I like, that to get a different point, is that I think the deep plane lift particularly works well on younger patients. I think if you nip it in the bud and get it early.
I agree. And it also seems to be less dependent on weight fluctuations, which is another thing that you're mentioning.
Right. Yeah, exactly. Because the skin is stretched out more with the weight, but when you do the deep plane, it is what it is. It's slid down in a pretty standard way. And so I agree with that.
Yeah. A lot of patients have fear of that. They ask me saying, should I get to my ideal weight beforehand? Because I heard that the facelift fails after, and I try to clarify for them what that means. And the way I explain it is the fear of this comes from mainly skin-only techniques, but also skin with minor muscle plication. The skin, as you pull it back and stretch it, it's dependent on the volume layers underneath. So if you end up losing that volume, you can collapse the skin, and kind of the lift tends to fail somewhat. The deep plane, you're actually moving half of those layers and repositioning them up superiorly anyways. So if you were to deflate, you just simply deflate, the lift doesn't fail. Anybody who gains weight will look younger. And loses weight looks older.
Yeah, you're moving the foundation, and so whatever happens above it is going to happen, but you've reversed the aging process in an overweight person or an underweight person. I agree with that.
Before we move on to the other stuff about facelifts, and this is more of an education for surgeons. I've had surgeons they do very clean, either lateral SMAS, extended SMAS techniques. And after coming and learning this technique, they go back and they try to do more deep plane, but they still tell me that they try to customize the surgery, meaning that for younger patients, they'll do a lesser kind of SMAS plication. For older patients who need a bigger lift, they'll do a deep plane. What do you think about that?
I couldn't disagree with that more, and I think you probably do too. I think it works for, by the same token, then I guess you could say it works for patients that are a little overweight. It also works for younger patients better, because that is the first thing you notice with aging. And I've done 38-year-olds, I don't do it routinely, but they come in and want it, and you see the faces change. It's become more rectangular, and the deep plane lift is the only way to reverse that. But yeah, it starts in the late 30s in a lot of cases. Everybody's different. I mean, different ethnic groups age differently, and people that their weight has fluctuated, obviously it's different. But I just think that the bilamellar techniques and the ones where you're separating the skin and plication techniques should go by the wayside. Will they? It's hard to say. I think there's so much great filler work, and now we've got Morpheus 8, which you encouraged me, and I got one, and I love it.
Yeah, it's
Patients
great.
love it, and Profound. I've seen some beautiful results that you've done on people which look like a facelift. But I think that I totally disagree with that. So
me too. Me too. And the logic, to just briefly kind of for people to understand, is the whole face droops together over time. And if you're looking at the layers as two distinct layers, I like to think of it as skin, fat, and muscle, or skin, fat, and SMAS. And then the lower layer, the mimetic muscles, another fat compartment, and periosteum. These are mimetic, they move. The fat here does shrink a little, and then the periosteum doesn't move. So you're not really drooping much on the periosteum. So the area that needs that effect is usually this thicker layer. And it's not that the skin aged differently than the fat or SMAS. They droop
Hmm.
together. So why would you go separate them differently and lift them differently if you have
Right.
the
It makes no
ability to?
sense. Yeah, and I
Makes no
think
sense.
any operation in the face where you're separating a lot of the skin, you're going to end up with potential irregularities there. You
Yeah.
know, little hematomas that organize and give you little lumps. And I think you probably feel the same way. I mean, I guess I did do biolamellar techniques. I didn't have a huge problem, but I noticed that when I started doing the one layer technique, I got much less incidence of having those irregularities and just,
Yeah.
you know,
And it's
you're
because,
careful, but it just, yeah, it doesn't make sense anymore once you learn the better technique. It's like you'll
yeah.
never go back.
And the deep plane is a less traumatic plane to dissect in. So when doctors say, I want to do the lesser by doing a SMAS plication, it's not lesser. You're actually traumatizing
Hmm.
more by cutting it into a plane that has a lot of dense connections. So you're
Hmm.
going just under the dermis, and there's a ton of
Hmm.
connections there that
Hmm.
you're sharply cutting through, versus the deep plane, you're just bluntly going through and splaying where there's no big connections.
Right. And that's exactly the example I always give to people to illustrate why it is that you know that gravity doesn't pull the skin down, because it's such a dense, tight, bloody, in a lot of cases, tissue plane. Gravity is not going to pull that down. Gravity acts, you know, on the path of least resistance, which is the sub-SMAS, sublatissimal layer. So that, yeah, it makes a lot more sense. And also, yeah, also that it's a gentle dissection, but a bloodless dissection. And so I think the recovery is actually quicker, even though it's a longer operation, it's a more complex operation.
Yeah.
Recovery is quicker and easier for most people.
Yeah, and the other thing I've seen, and I'm sure you've seen a lot of this because you do so much revision work for other doctors too, is the worst scarring that I tend to see are on really young patients who got an very early, like mini facelift, or men who
Hmm.
went and got, these kind of techniques. And um, the reason I think that's happening is because men, or these patients who are young, they have denser tissues. And you can't just go in and cut out a little skin and pull it up and kind of stitch it together. You actually have to go
Hmm.
and do more work in these patients to release all the tension and bring it up with no tension. So I've
Hmm.
seen horrible scars on 35-year-olds who go and get
Yeah.
these mini lifts,
Yeah.
and they're just
Or
hypertrophic
yeah,
everywhere.
and I'm sure you've seen the unfortunate, like, you know, patient that had a facelift when she was 30 and didn't need it, but she had that type of facelift, and their skin at that age, I think, is thicker. And so they're going to get, I've seen just some horrible scars, and you really can't fix that until they get older and, you know, either gain some weight or
Relift.
age a little bit more.
Yeah, so that's why I advise the doctors that come and observe that you need to just really
Hmm.
understand what the point of this whole thing is, which is to lift without any tension. You want to release, lift without tension. That's
Yeah,
kind of the basic
exactly. And that's the
understanding.
whole thing. And that's why I'm really passionate about educating people. And I've done my own, you know, sort of work, learning the anatomy, measuring millimeter by millimeter of where the ligaments are, because you really do have to get in there to get that smooth effect. You have to release them all, and they have to reset it. And I personally use a lot of sutures. I mean, I use a lot of buried permanent sutures to anchor sorry, I'm not supposed to touch my face, but I'm going to watch. It's for educational purpose. No one's here.
Yeah.
But you have to anchor them with a lot of sutures. I think that helps you get a nice smooth result. One
Yeah.
thing I've started doing, that I may have told you about, is the Scarless technique, where
Yeah.
I, you know, and it's the same operation. I always tell patients that, you know, I think we both got to the point where it's state of the art, where you can make this, and the way you design the preauricular incision, get to the point where it's invisible. So it really isn't an issue. But then I start thinking, you know, I'm getting older. That one incision, just like the stigma of that incision, would be the thing that might stop me from getting a facelift. And that's
Hmm.
true in a certain number of people, especially here in LA, where the hairstylists, the makeup artists they're looking really close, and people focus on that, and they don't focus on the overall gestalt of the operation. So I started doing it, you know, endoscopically with an incision here and here, several years ago, and I did a few, and now I have so many patients that are on the younger side, 40s, early 50s, and I found that, and this is not something I share routinely, but I will here talking to you, is that what I found is that when you do a facelift, deep plane or whatever, particularly a secondary facelift, but in general, the cheek and jawline goes up, but the ear goes down, and it always goes down, and I anchor it, and you know, to the periosteum to try to prevent that. But what I realized is that, particularly in cases where you're not going to remove a huge amount of skin, if you can get access and you know the anatomy well enough to access the deep plane from both up here, and then you make your incision back here and access the lower part from here, you connect them through, it's all under direct vision, and I use a scope when I need to. Then what happens is you're going to have a fold of skin right here. So that's obviously the issue. What I realize is that to cheat that skin out, as to put it in tailoring terms, you pull the ear up. and
Hmm.
anchor it, and then you solve the problem. You do get a little pleat here every now and then, but then it relaxes.
Yeah.
And I always, when I'm signing up a patient for that particular operation, I always tell them that I won't do it unless they agree that there's a chance I might have to make that incision. I did it. I've had to do it once in the past 3 years, but haven't otherwise. But I think in a lot of cases, when you're doing, like I just did one a few weeks ago, the last one I did, where the patient did have to have the incision and she had a lot of skin to remove. So sometimes that works out that way, but it turns out really nicely.
Yeah, I got to come watch you do that. I feel like if I try that on my own, it'll be a
Well,
10, 15 hour surgery.
yeah, you'll be able to. You're one of the few that I would say, okay, Ben, I would share my secrets with you
Thank
on
you.
that one. It would be fun. I mean, it's a joy. It really is. And also, as you might agree, it's nice to finish and you don't have to suture this together, because it's also pleasurable to do, but it's a lot of work and it adds time. I think
Yeah.
the time factor is about equal, just because the dissection is more difficult than just doing it through those areas. But yeah, we'll do that someday.
Yeah, and the patients who are going to undergo lifting and things like that should understand also that you do want the doctors in general who are always changing, always learning, and you never have to worry, even with something like this, let's say, that anybody is doing an experimental surgery. Like Dr. Manny is performing the same exact surgery without incisions, and he has backups. So the same thing when I'm trying a new technique on like a nose or something. I start out the technique, and worst case scenario, it took me an extra hour, it took me extra time, but I can always go back and do the original technique if I wanted to. So in this case, when you're starting, that would be my worry is, okay, well, I'll have to go cut anyways. So, we have a backup.
Yeah, which is kind of you're kind of it's disconcerting at the end. We're like, oh shit, now I have to do it anyway. But yeah, it's a matter of judgment too. Before I go in, I'm like, okay, I'm 95%, and if I don't have a 90 to 95% confidence level that I'm going to be able to do it, I won't get the patient too worked up in favor of it. But it's been good, and it definitely, and you get a nice vertical vector. The necks are good. There's a little more swelling right in here from time to time, but all these problems now with technology are fixable. So if there's an issue like that, we do lymphatic massage. I have a shockwave machine now, which actually I don't know if you use that or know about that, but it's the same thing they use in S-Wall for lithotripsy for kidney stones, and it works really well for swelling. I've used it on like sports injuries, tendonitis and things like that for myself, and it works really well.
Oh, that's cool. I haven't seen it for swelling. That'd be cool to see.
It works. It kind of pop. You can feel the either scar tissue or fluid pockets just kind of pop. And so I've had to use less lymphatic massage just because of that. It helps. I'll show you I have it in my office once we get
that sounds very cool.
clearance from Mr. Trump.
Nice.
And the mayor or the governor.
The other thing I want to talk to you about is the mist treatment.
Well, I like to call it mist procedure, because if you mistreatment slice together too much, I'm going to do a mistreatment on you.
Yeah.
And that's not, you don't want to start out on the wrong foot, but anyway, no, I'm just joking. Mist procedure is essentially nanofat. I have a little tweak and a few little things that I added, which is why I call it mist. It stands for minimally invasive stromovascular transfer, which is obviously people will run out the door if you tell them that, because it sounds very invasive and weird. But it's just a procedure that you do also, and I think you're probably the other person that has the most experience with this, probably in a broad area. Where you're taking, we do gentle liposuction, take out whatever fat you need. And fat is the richest source of stem cells by far, including bone marrow, donor, all those other potential sources, cord blood, and all those things. Fat is a much richer source of stem cells. So we take the patient's own fat. And I think the other key is that you want to inject it into the body as quickly as you can. You take the fat out and then emulsify or kind of pulverize the fat cells out. So the only thing that you're left with are the stem cells and supporting cells, which include pericytes and other cells where vessels form from. And you can actually see, I have a video on my Instagram where you can actually see microscopically the inosculation, the new blood vessels forming from pericytes. After about 28 days, they start forming. And so I hate to say magic bullet, but it's like a fountain of youth for the skin. It's a dramatic night and day difference. And I was frustrated doing facelifts where people would still have the fine lines, and you don't want to pull so tight. And we're not either doing a lot of skin pulling anymore. So you reset the muscle, but they're still going to have fine lines. And so I'm preaching to the choir here, but as you know, it works really beautifully for that.
But doctor, I don't want my face to look fat.
People say that, and yeah, it's not fat. It's everything but the fat. So yeah, fat transfer has its own kind of stigma, and it can. Like one thing I don't like, I had a patient I know is a friend of mine who gained a little bit of weight afterwards, and the face got puffy. Then I had another patient, this person's pretty well known, and she came in and said, "Did you do so and so's filler?" And I said, "No, she just gained weight." And so I have a very specific thing: if you're going to gain any weight at all, you can't control your weight, I'm not going to do fat transfer on you. And so
Yeah.
it's a little bit of a catch-22 because they need a little bit of fat to do fat transfer.
Right. And there's a big difference between fat transfer and nanofat or mist. Patients really need to understand that fat transfer, you're trying to augment volume. You're trying to increase volume in the face.
Mm-hmm.
And yes, it does have some other benefit depending on where you put it or how you inject it. But when you're
Mm-hmm.
doing the mist procedure or nanofat injections, you're not trying to volumize by adding in a filler. What you're
Right.
trying to do is get the body to heal itself, to rejuvenate, to refresh itself. And you're kind of calling in the immune system to come heal the whole area. That's really,
Yeah, if only we could do it for coronavirus. That
I
would
know.
be that would be the next, the holy grail. But
So
actually, I think they are using convalescent serum now. But
yes,
no,
yeah.
but yeah, exactly. Well, also, Ben, that's part of the reason I came up with the mist, because nanofat is a misnomer. It's bad marketing,
Hmm.
and because it's not fat. So that's just one of those things. It's kind of like facelift. It's gotten a stigma,
Right.
but it's a little bit different because it's just not accurate. And then, with mist, I have another delivery system that I use at the end, which I think makes a big difference with microneedles that have that are hollow, that actually deliver it a little bit deeper into the dermis. I also routinely do Morpheus before if the patient's amenable to that, because I think that the Morpheus creates little micro injuries, and
Hmm.
stem cells are inherently going to be drawn more to areas of injury. That's pretty much well known. And so that helps. Now, there's
Yeah.
another thing that I know you do. You do some certain tweaks on your nanofat, which I've seen your Instagram posts about that.
Hmm.
But what else do you, not that I'm supposed to be the one asking the questions, but I
So
know that you
no,
do.
please, it's a two-way thing. So yeah, so what I do with the nanofat treatment is I called it fat. Again, same reasoning is that I wanted to make it a little more fun than just kind of people thinking it's a fat injection by itself. So
Right,
fat is it's platelet hybridized adipose. So the
right.
same idea, but the what we're doing is I'm using two types of fat. One is nanofat, one is whole fat that's aspirated, so the lipoaspirate, and then I'm using platelet-rich plasma at the same time. And the two of them together, the three of them together, have a really nice effect. And I've been using it for scars, for burn scars and contractures. It's a huge change in terms of people who don't have good mobility and the SCM from
Yeah,
fibrosis.
yeah.
And I've been using it for hair loss, and I've had more success with that for hair loss than A-cell or stem cell injections or anything else that anybody's
Hmm.
done.
And PR, including PRP, just alone, right?
Oh yeah, yeah. It,
Yeah.
it is substantially better, and I know that it's very clear to me without doing a double-blind randomized study, because when I do the fat treatment, the nanofat, fat, and PRP, the patient comes in every single time a month or two later saying, "No, no, my hair definitively stopped falling out."
Hmm.
Versus when I do the PRP or A-cell, they're a little more wishy-washy about it.
Hmm.
And it's a very stark difference when you do follow up with those patients. So I started doing it more and more for that. And for doctors who don't understand it, I try to tell them I don't understand it. I don't, I
Right.
reasons why it might work. I have, my theory,
Hmm.
but in reality, I don't have a scientific explanation that I can prove. However, my experience is substantial from what I've
Hmm.
seen. And I can
Hmm.
show you photos that the patients had no other treatment. It's a burn
Hmm.
scar from 10 years ago.
Hmm.
They're contracted, they can't move. I did one
Hmm.
treatment on them,
Hmm.
and I physically can manipulate them more, and they can do it themselves. And it
Right.
helps with trismus, opening the mouth, with neck movements and everything. So,
Hmm. Yeah,
uh,
I've done the same thing. I've done mist on some of the burn patients, domestic violence victims that have these horrible total facial burns. And there was a patient that we did from the UK. He's a pretty well-known guy named Andreas, who had a kind of a mistaken identity domestic violence rage incident where they burned his face with acid. And he was able. The other thing that I noticed what happened on him is that it has a photoprotective effect. So he can go out in the sun now and no longer he can actually tolerate the sun, where before it was just burning him. And I think that nanofat or mist has a protective effect. Not only does it reverse sun damage reliably, the little spots and freckles, and
mhm.
but patients have more tolerance to the sun. And you're right, it softens those burn scars, and it keeps working over years. And for the anti-aging effects, I've noticed the same thing. I'm going to have some 2-3 year results where it keeps getting better. And
Yeah.
I repeat it within a year or 6 months. Like a lot of times a patient will come in for mist and then they'll know they want a facelift, but they need to work with their schedule to get the 2 weeks off of work for recovery. And so they'll have the mist first. And then if they do the facelift within, let's say usually it's about 3 to 4 months, I'll do it again. And I think it does have kind of potentiates itself and has a little bit of an exponential, because and again, don't know why, but my theory is that it's because the stem cells that are there are still there and you can reactivate them with more of the supporting cells and factors, humoral factors.
Yeah, I agree completely. And what I would love to point out to when I teach residents who don't really understand the world, you're going through residency and you don't really know who's good, which doctors are good, what to really listen to. Dr. Manny and I both are facelift surgeons, but we know a lot about skin and we do skin treatments and we do fillers and injectables. And I feel like all these things really, to understand the face, they go hand in hand. I feel like doing the injectables, doing the skin treatments has made me a better facelift surgeon because my understanding of aging is better because I keep looking at faces over and over again, not just one a day for surgery. I was seeing 15, 20 a day.
Yep.
And you see all the deficits and you see also where other doctors went wrong. So you're learning so much. So I try to tell the residents that come in, if you really want to be a good aging face surgeon, you better get good at understanding the skin and understanding injectables. And that's why I'm not somebody who just says, oh, well, I'm just a surgeon. I don't believe in injectables.
Right. Yeah, I've decided that that's what I've sort of become is the people, and I end up doing multiple procedures on the same patients, year after year because they love the results so much. And I totally agree with you. I love surgery, like I know you do too. And so I was just happiest operating all the time, which I still am. But I found that looking at the artistic side of it has become even more of a pleasure because for exactly the same reason. And also, the more you have in your armamentarium to treat these little problems, the more you're going to notice on people walking down the street or, in your office. And, like I can fix that. So you get a real confidence saying, okay, I have a multiple things that multi-armed approach, and I can target each of these problems, whether it's a little dark under eye circles, and someone that's a candidate for a lower bleph. You can also do the mist or do the nanofat and help with that. But I totally agree with you. Just once I started really keying into the fine lines, if you can't do anything about it, it's kind of disappointing. And I never liked filler for fine lines. I just think that, especially in the upper lip, people were, you get people that put filler in these vertical lines and they like, I want to have a filtral column now. Well, then you look like a monkey and it doesn't look, you look older and more simian. And so I just don't like that. And, but nanofat or microfat works particularly well for the perioral lines. And then you don't have to numb them with Botox or freeze them with Botox.
Yeah. And I feel like, especially if somebody's going through their training, they should be doing a lot of this stuff just so they understand it. And in the future, even if they selectively go into just surgery, they have less of a chance of mistreating somebody. So the mistreatment,
Right. Do the misprocedure, not the mistreatment.
Yeah, not the mistreatment. But I feel like they're better able to analyze and assess, just like kind of education I got from going to like dental programs. Yeah, I'm not going to be a dentist and do a dental procedure, but I understand what treatments are there. So some patients come in and I automatically say, you know what, this isn't for me. This is orthognathic. You need to go to an orthognathic surgeon.
Right. But yeah, I never really had as much of a passion for skin and dermatology as I do now, just for the same reason. The more you have at your disposal. And I think that the things that we do are better than the things that are happening in offices where they're adding filler or also peels. I'm not a fan of peels. I think the beauty of the nanofat or mist is that it's a constructive procedure where you're actually enhancing the skin by adding blood supply. In theory, you're thickening it, you're adding. And the other thing is, I know you have a very informed opinion about this, is that people talk about collagen. We're going to add collagen, it's going to rebuild collagen. And I tell people, this is kind of horrifying, but I do say this, you could take a cheese grater on your forearm and grate it, and then you're going to have more collagen. So if that's, just do that and you don't have to pay me. But there's different types of collagen. I know you've talked about this, and you know a lot about the science here. So about the different, what you're triggering.
Yeah. And fibroplasia is very different than healthy collagen formation. It doesn't mean we can't use these things to our benefit, but we better, as the doctor, we better be weighing the risks and the benefit. You're treating somebody with HIV lipodystrophy who is thin and skinny and has no fat and in a compromised immune system. You have no other good choice, so it's a good idea to go form scar in their face. But somebody who's young, healthy, supple, has other options, then yeah, you don't want to cause bad collagen formation.
Yeah, and I think that reminds me of something else, which is Sculptra. And I'll ask your
That's
opinion
what I was
on it.
talking about, basically. Yeah.
You're right. That's what I figured, and I agree with that. And Sculptra, there are people, particularly people in this town, that do a beautiful job with Sculptra. As a facelift surgeon, I hate it because it makes you're just chipping through rubber when you go
Yeah.
through Sculptra a lot of the time.
Yeah.
And the other thing I used to use is fibrin glue, which I loved for healing and for hemostasis. But what I found is that if I started once I started a few years ago doing my own secondary facelifts, people would come back, they're ready for another one after 10 years or 12 years. Trying to chip through fibrin glue was a torture, and it doesn't compromise the result, but I don't use it anymore. And plus,
That
I
was
think
my fear, actually, of causing a more inflammatory response as it heals.
Yeah, it's inflammatory, but just it's long term. And as you know, most of the time in a secondary facelift, the operation, particularly in a deep plane, is no harder than the first time,
right?
Technically. But when you have the fibrin glue oral Sculptra, it's all bets are off. It makes it harder.
Yeah, Sculptra makes me almost fall into the wrong plane all the time as I'm trying to get across it.
It's harder.
Yeah, and it's not replacing fat. It looks like gray, hard fat. So I try to tell doctors who do it, don't stop doing it. You can do it. Just really pick who you do it on more selectively. And don't ever think, ever for 1 second, that you're doing something healthy for that person.
Right.
It's not a healthy thing you're doing and injecting vitamins into their face. It is forming scar tissue, and you can use it to your benefit, but do not discount what it's doing.
Right. We have a lot of questions.
Yeah, well, we've got a lot here, so I've got some for you.
Cool.
I tell people when I'm doing hair treatments, as far as, does nanofat work, I tell them you have about a 90% chance that it's going to have a benefit for you. And I try to explain what that is. And I feel like with skin procedures, it's about the same. But I tell them, no, it doesn't show a clinical response for everybody. Mm-hmm. What do you tell them?
Yeah, I think it depends on the need. I think if people have, and there's a middle ground. I think people they're really far gone with, solar elastosis, and like the desert bearing people in Palm Springs that just haven't, or people in Malibu that have never worn sunscreen, which they're out there, and they have that craggy skin. It's not going to be night and day, but it's also probably the best option. Those people maybe need a phenol peel, which I don't know anyone that does those anymore. I don't do that, but
I actually, for somebody who does phenol, there's somebody in LA who is doing it. I think it was Dr. Binder was doing it, but I send them up to Dr. Ben Simon, I think he's in Portland.
Okay.
Yeah, so he does the most amazing.
How many phenol peels is he going to be doing in Portland? I don't know. That's like
no,
it's raining every day there. But anyway, that's a different question.
Yeah. So another question: What are your thoughts on
that one?
PDO threads?
Yeah, I don't recommend a PDO thread lift for someone in their 30s. I also don't recommend it for people in their 20s, 40s, 50s, or 60s, or 70s, or 80s, or 90s.
Coming from a facelift surgeon,
it's great. So I don't know how you feel about that, but
we're both facelift surgeons, so it's like I don't see big benefits from it. I have seen benefits from it, but when I'm playing the odds, and then I have this kind of instinctual issue with it from, I know, my hand knows how it feels when I'm in a face and I'm trying to get through those things. I personally don't like doing it. I do think there's a role for them in the world of aesthetic where, the practitioners can make an argument for improving the result of their fillers by doing it. But I would argue equally that I could do Morpheus or Profound and then do a little filler on you and get an equal result that's going to be healthier for you in the long run. So
right. Yeah, I just think the whole argument that there were threads back in 2005 that became a big rage, and that was before there were so many other non-invasive options, and before there was this proliferation of non-surgeons doing this type of work. And those were permanent threads, barbed threads, and they just kind of didn't work, and they became a real problem because they would cause complications, and the recovery wasn't quick, wasn't easy, and there were even nerve injuries, I think, and people had bruising, and then they would fall down after. Yet I think it's maybe it'll last 6 months, but you don't want to overpromise something like that, because in what I've seen with people that have had threads, they didn't really see much of it. A lot of them didn't work for more than 2 days, but at the most maybe 6 months.
Yeah.
I think I'm biased because I love doing surgery, and I know I can offer things that work. And I totally agree with you. The combination of Profound or Morpheus and filler is smoother and better, and That's what
Yeah,
I
and you
would
don't
do.
get those indentations. You don't get, things that you can get, because you can change the tissue turgor and suppleness with doing sculpture or threads, and people don't realize that. And especially if it's a little superficial, it can be something that's very
Yeah.
permanent and noticeable on somebody. And maybe
Yeah.
it's 1 out of 10, maybe it's 1 out of 50 people, but
Right.
it's a risk that we have to
Right, and
know
that
about.
leads to the point of, we're not operating on a picture. We're not operating on a sculpture. We're operating on a face that moves and animates and has nuance and gesture and expression.
Yeah,
And so, you want to make sure that you keep that smoothness and keep the tissue turgor, and that's youthful. You want it to look natural.
yeah, I
So there's a
agree. So
dynamic component to facelifting.
I think this is a good question for filler overall, because people think that since it's temporary, some doctors would try to justify the use of filler just by saying, well, no, it doesn't matter if I put filler, it's not going to cause a permanent effect,
Mm-hmm.
which I think differently. I use a lot of filler, and I like to use it responsibly. And I have seen overfilled people when people have
Mm-hmm.
too much in their under eye cheek, and you do get a tissue expansion effect over time from it, where once it
Mm-hmm.
goes away, you will be saggier than you would have been.
Mm-hmm.
Putting small amounts for accent along the jawline, I do it all the time. I have no problems with it, but I'm never trying to go too far. I'm not trying to build up what an implant would do or what
Mm-hmm.
jaw surgery would do. I like to do little
Mm-hmm.
bits of accenting and kind of keep it safe,
Mm-hmm.
because I feel like anytime it's going to start drawing in water, you're going to lose the bony accent anyways, and it just gets puffier and heavier.
Right. Right, I agree with that. Yeah, and I think, yeah, there's a little bit of a stretching effect. To me, the main thing is if too much of it is done, it changes the character of the face. It changes the way the face moves, and it can look unnatural. And you get these apple cheeks of people that do it too aggressively. So that's, and also just I'm a surgeon, so I don't want to be in my office all day injecting filler. I feel like it's a waste of my training.
Yeah.
But I think judiciously, I do it in the nasolabial folds and in certain areas, but that's just something I've chosen to generally not do. I talk a lot of, especially in lip filler, but I do think that filler is the best option for lips in a lot of cases. I do fat
Me
in the
too.
lips occasionally, but I just don't,
It's not
I
as
think filler is
predictable.
a great option.
Yeah. Filler, you could play with it more. If it moves, you could fix it. So,
Mm-hmm.
I agree with that. So for younger patients, and I get this question a lot, I try to explain to them that there aren't very many big trade-offs now with the way that if you go to like a facelift surgeon who does very, very substantial, good facelifts with no scarring, there's not much of a trade-off other than healing time. You're not going to look fake. You're not going to look done. So
Mm-hmm.
I say in those scenarios, I look at two things. I look at, number one, is there a lesser technique that would be adequate for you, like Morpheus, profound skin tightening, filler, those
Mm-hmm.
kind of stuff? Or if we're going to choose that that's not adequate, is this the only thing that's going to get you better? It's more of a physical manipulation that I say, you know what,
Mm-hmm.
you do this. This is the
Mm-hmm.
only thing that's going to get you there. Do I agree with what you want?
Mm-hmm.
And then I say, okay, the age doesn't matter so much. So I've done 27-year-olds who have had bad acne and super droopy cheeks, and I justify it by saying, you know what, they have all this soft tissue. It's
Mm-hmm.
just, I don't care if it's called a facelift. This is what's needed. I got to get it back up,
I agree.
and do it that way. But most
Yeah.
patients who are not acne patients, not chubby cheeks, 31, they're usually doing skin tightening and then maybe some
Mm-hmm.
filler. What do you think? Do you have like a? I'm sure you've heard that
Yeah,
a
for
million
this
times.
question, best technique to lift the cheeks and eliminate the appearance of nasolabial folds. 31, yeah, I would say that's right. I think Morpheus 8 or Profound, a little bit of filler, nasolabial folds at that age. Some hyaluronic acid filler would work really well, I think, or fat if they're ready for that, if they want to do that, some autologous fat.
Yeah. So here's a question: does sculpture eventually metabolize and disappear? So this is a kind of good question, because we could talk about Sculptra and then briefly like Radius and those kind of things. So Sculptra does eventually disappear. It might take several years because you can have little granulation or little granular bits that stay. But the whole purpose of Sculptra is not to volumize the face by itself, is to form the scar. So it's important to know this, that if you do a PDO thread, and people say PDO threads are temporary. Yeah, the PDO thread portion at some point will hydrolyze, and your body will hydrolyze it and eat it up. But while it's sitting there, it's causing scar formation around it. And the scar could benefit you, it could hurt you. We don't have predictive kind of power over that. We don't know what it's going to do. So when we do threads or sculpture, these things, we try to do, I would say, smaller amounts in deeper planes, but there's
Mm-hmm.
no way to know. But either way, you never assume that the effect is temporary, even though the thread or the sculpture is gone. And things like radius almost never go away. Radius and those, when it's in the soft tissue, they kind of stay there. And radius, silicone, different things, but those almost never go away.
Yeah, so those you got to be really careful. I'm sure you've seen too those. What were those ones called? The PMMA beads
Yeah.
with the. And I saw so many people that just had itchiness and just destroyed, you know,
balls in the
stuff.
face, and
yeah.
And you can't inject a gallon of steroid and 5-FU. It's not going to make it go away.
Yeah, just exactly. Yeah, ruined.
Yeah. So same thing when people ask about the only reason I bring this up is that we see a lot of doctors kind of just filling nasolabial folds as the first thing. Do you have like a protocol or a little algorithm that you go through when you're looking at somebody's nasolabial folds or laugh lines?
Well, it depends on how old they are, and I think those things can vary. But again, I think you have more nuanced approaches to fillers, just because I generally will just use Juvederm in the nasolabial folds, and I think it works pretty well. I rarely would use a huge amount. If someone's older, one thing I don't like is an older patient with thin skin and they have all that filler in the nasolabial folds.
Yep.
You put a river in the valley, you know, and you can just see it, and then the face doesn't move as naturally. So,
I say I like to put very small amounts of filler in the face.
Yeah.
And I think nasolabial folds are over-treated and people look like monkeys. So you have to really look at what's causing the nasolabial fold to have a shadow.
I've been happy with fat too. And, you know, they have the little cannula with the fork, with the little pickle fork that you can release some of the adhesions.
Subsize. Yeah.
Subcision can work well with that too. Yeah. And then obviously if they need it, then you're going to do the deep plane facelift. That will solve the problem.
So how do you correct cheek tissue expansion from filler? And this is what I love the radio frequency devices for most people, is that I don't have to go dissolve filler much anymore. Dissolving filler in the mid face can be very treacherous. So I'm always worried about dissolving here, because what patients don't realize is that dissolver gets rid of hyaluronic acid, and hyaluronic acid is the main particle in your skin that's keeping the water in there. So it's what keeps you from being, you know, shriveled and dusty. So in areas like this, you have a high amount of hyaluronic acid content because the SMAS is thick in this part of the midface and the dermis is thick in that part of the midface. So if you put hyaluronidase, you're shrinking the dermis like this, and you're shrinking the SMAS as well. So I like to avoid dissolving if I can, and that's when I like to use radio frequency treatments to tighten things and see if I can get away with 1 or 2 treatments rather than lifting somebody who's young. But I certainly can lift. The benefit of the radio frequency is that your body metabolism of the fillers goes up too. I'm sure you've seen a bunch of these overfilled LA cheeks. I've seen a few. Do with them?
Yeah, now that you mention it.
Just one here and
a couple here and there. But yeah, that's a very good point with the hyaluronidase. It does dissolve some of the normal hyaluronic acid, and also I think that would be an argument. Don't get filler in here. You know, all that's going to do is accentuate your nasolabial fold. And so that's, if you can't reverse it, that makes sense. That's a really prudent approach to do it that way.
Yeah. So in general, I think everybody's just got to be cautious with all treatments. There's no, generalized blanket statement we can give as to doing fillers or doing facelifts or anything. You just find the best doctors. But we've now been talking for an hour, so they're gonna Instagram's gonna cut us off. So for anybody who follows me who wants to learn more from Dr. Manny, he does a lot of educational videos, which are awesome. They're really, really good. And you can just see his Instagram here is Dr. Marc Manny. Your website is also, I think, Dr. Marc Manny, isn't it?
It's marcmanny.com.
Marcmanny.com,
I think. I haven't paid much attention to it. I know the website. It's all about Instagram nowadays, but I think I still have a website. But yeah, it's marcmanny.com.
Yeah, it's funny. I've got patients who come in and they're like, I've only saw one nose job that you did. I'm like, what do you? Did you go on the website? Right. Like, no, I thought it's on your Instagram.
Yeah,
only 5 years ago they would have checked, not anymore. So yeah, thank you so much for taking the time with me. Hopefully we'll get to talk again and go over some diagrams with all the fancy drawings and illustrations you've done.
Absolutely, let's do that. Thank you, Ben. It's a pleasure.
Right. Thank you.